honored to present to you Dr. Mohammed AL Zayed, Head of Molecular Imaging and Nuclear Medicine and Director of Fellowship Program in King Abdulaziz Medical City in Riyadh. And his talk will be about the role of PET-CT scan in breast cancer staging. ما عندك طب ارسل لك I can again
Dr. Mohammed, can you please proceed?
في يعني كذا هم ارسل لي اياها كذا عشان يصير اريح انك تقولين
يعني ما بس هيك.
ايوه بس هي توك انا قلت هذا السيشن وقلت عنوان هذا واي انتروديوس هذا السبيكر
بس هيك.
ايوه
طيب يعني لازم نيجي هون.
ايوه بس when you present when it's دكتور
بس لازم تكوني ملتزمة بالوقت.
ايوه بس ما قالوا لي اهلا كيف حالك
يا دكتور؟
اهلا وسهلا كيف الامور؟
دكتور كيف حالك؟ اهلين الله يسلمك.
Dr. Mohammed, please share your screen.
السلام عليكم. طيب بسم الله الرحمن الرحيم. Thank you, Dr. Najd, for the introduction. It's a pleasure to talk with you this afternoon. Take this opportunity to thank the organizing committee for the invitation and congratulate them for the success of this event. This afternoon, I'm going to talk about the role of PET-CT scan in breast cancer staging. And I have no disclosures related to this presentation. And for the sake of time and due to a limitation of time, here I'm going to focus my talk on a role of PET-CT scan in staging and its link to practice guidelines. And this mainly will be focused on FDG PET-CT scan. So whenever PET-CT is mentioned in this presentation, it's meant to be FDG PET-CT scan unless otherwise mentioned. Well, as you know, the NCC guidelines does not encourage the regular use of imaging in general for staging breast cancer patients with limited disease to the breast. And it indicates that the role of staging might be considered in locally advanced breast cancer. This was specifically mentioned for PET-CT scan as well. So PET-CT scan, as per the NCC guidelines, is not recommended for staging early disease. And it was mentioned as added tool in patients with equivocal or suspicious lesions on standard imaging. And interestingly, in the recent guidelines, it was added as well that PET-CT scan could have also a potential role in patients with locally advanced stage to detect lymph nodes and unrecognized metastasis. As we know, guidelines are in continuous progress and change over time according to the available data. And in this talk, I'm going to just review available data to try to understand future directions that may find its way to the practice guidelines. As you know, FDG is a glycolysis parameter, and it does reflect the avidity of tumors that we are imaging, and detectability is on PET scan depends on different parameters, and one of them is the avidity of a tumor to the tracer that we are using. In regard to the breast cancer, the detectability depends on the tumor grade. So higher grade tumors like tumor with grade 3 has higher detectability on FDG PET scan. Also, histological subtypes indicates or determine the sensitivity of the scan for both primary and metastatic setting. The KI index, tumors with B53 mutations have higher FDG accumulation. The hormonal receptor status as well has a value in determining the detectability of FDG PET scan, as well as the tumor phenotypes. So like triple negative tumors will have higher FDG avidity, which will reflect in detectability of disease either on the primary site or metastatic areas. So let's start with the role of PET scan in T stages. Due to limitation of spatial resolution and some limitation of specificity as well and variation in histological subtypes, the PET scan is not the best modality to evaluate the size of tumor or its multifocality when compared to MRI. And it was found to have accuracy in determining the T stage in only 54% as compared to 77% with MRI. PEM, which is the positron emission tomography, has much higher sensitivity than regular scans, however, still remains below the MRI. Therefore, PEM can be considered in areas where, or situations where MRI is contraindicated. So obviously, PET is not the area of strength for T staging. However, the incidentally found breast lesions on PET imaging should be investigated and looked at seriously, as 30 to 40% of them tend to be malignant. As we see in this case, there was only 8 millimeter right breast lesion, which was biopsy proven cancer. Similarly, for the axillary nodal status, the PET scan sensitivity is inferior than what we hope, and this is mainly related to spatial resolution problems. So PET scan can miss the micrometastases, and for that reason, it cannot replace sentinel lymph node biopsy. And a meta-analysis of 19 studies which included more than 1,500 patients, the sensitivity was only 66%, though with very good specificity, and the predictive value, positive predictive value was 80%. And some authors think that the with this high positive predictive value, positivity in PET scan can justify radiotherapy or lymph node dissection. However, the main limitation is the sensitivity because of the micrometastases. So again, PET scan is not the best tool to evaluate nodal status in the axilla. Then what about the extra-axillary lymph nodes? As you know, these are clinically occult, and their identification may result in a modification and extent of surgery, as well as radiotherapy, and of course, influence the stage and prognosis of patients. PET CT scan is much superior than conventional imaging in detecting extra-axillary lymph nodes. And different studies have shown that the prevalence of detectability or the prevalence of these lymph nodes found in PET scan is high, and was found in one study to be 28%. And another one was 16% when they only looked at the internal mammary lymph nodes. Of course, these numbers are related to stage 2 and stage 3 disease. The detectability of axillary lymph nodes correlates with the different parameters. So it's higher with grade 3 tumors, HER2 positive tumors, and triple negative. So triple negative disease. And again, the positive predictive value is high with a PET scan for extra-axillary lymph nodes. So this is an example of patients with left breast tumor. There is axillary level 1 lymph node. However, there was a detected internal mammary lymph node, which was not expected based on conventional imaging, and this has disappeared with the rest of the disease on post-therapy scan. Okay, so then what about distant metastasis evaluation of bones on PET scan? Let's start with bone metastasis. The sensitivity of PET is much superior than conventional imaging, including bone scan and CT scans. And this is true for lytic as well as for mixed bone metastases, as well also for the bone marrow involvement. The sensitivity, specificity, and positive predictive value and negative predictive values, as well as accuracy, are excellent for PET and bone metastasis. The only downside is the PET scan detectability for osteoplastic lesions or sclerotic lesions, where there will be a variability on the metabolic appearance on PET scan. However, as you know, nowadays, PET scans are performed with CT scan as a complementary part, and these sclerotic lesions will be easily detected. So this is an example with a patient who was found to have a metastatic left sacral lesion, which was not picked up on conventional imaging. And another patient with also left sclerotic bone lesion that was found on CT. However, on PET scan, this was negative, indicating its benignity. What about lung metastasis? It has its main limitation is size. So the sensitivity of PET scan for small nodules is the negative point. However, it has very high specificity and other parameters as well. Therefore, the sensitivity of a CT scan is much higher due to size limitation. However, once the lesions comes close to 1 centimeter, or let's say more than 6 or 7 millimeters, then PET CT scan has excellent performance. For pleural metastasis, FDG PET scan has excellent performance in terms of sensitivity, specificity as compared to the conventional imaging. As you see, it has a sensitivity reaching up to 100% in the publications, as compared to 50% only with HSCT. Same is true for liver metastasis when it's compared to conventional imaging. PET has higher sensitivity, and this study was comparing FDG to CT scan and detectability of liver lesions. So as you see, this is a patient with a left breast mass and recognized the liver metastasis that was only picked up on PET scan, as well as a sternal lesion. So from the previous slides, we see that the strength of PET scan is not for the local disease in terms of T or axillary lymph nodes. The strength comes in N3 disease, as well as non-nodal metastasis. And the biological characteristics of the tumor also have an impact on the available data as we have mentioned earlier, the extra-axillary detectability of lymph nodes correlate positively with aggressiveness of disease. So if it's higher with grade 3, higher with triple negative, higher with HER2 positive disease. Also, the rate of extraskeletal metastasis was higher in triple negative and HER2 positive disease. The downside of PET scan is the lobular cancer, where the stage modification is lower than ductal cancer. So in one of the publications, it was 11% as compared to 22% stage migration from stage 3 to stage 4. Okay, the impact of PET scan on staging and management as initial staging modality in breast cancer was evaluated in a recent meta-analysis, which was published a couple of months ago, which included more than 4,000 patients in 29 studies. And in that meta-analysis, they evaluated the performance of PET scan in stage migration, as well as in the alteration of the selected treatment modality. And also they evaluated the role of PET in a modification of a treatment intent from a curative to palliative intent. So their pooled change in stage was 25%, and this was higher with the grade 3 tumors. With the stage 3 tumors. For stage 2, it was almost 20%, and it was less with variability in studies for stage 1. Change in management was 18%, and this was significantly correlated with the age, again, grade of tumor, and advanced stage. The change in management was shown to be implementing both the intermodality change and intention to treatment with 74% and 70% respectively in their meta-analysis. There was a prospective study which has studied more than 250 patients, and it again shows that the PET scan has stage migration in almost 30% of patients, and this stage migration was related to N disease by finding unexpected nodal metastasis, as well as for extranodal metastasis. And the detectability of unexpected metastatic disease was higher as the stage of tumor increases. So it has reached to almost 50% with the stage 3C. And the change in stage was obvious starting from stage 2B. In a retrospective study, which was recently published in JNCCN, which included almost 200 patients of stage 2 and stage 3 breast cancer, where they compared the performance of conventional imaging, meaning CT scan and bone scan in one group and PET CT scan in another group. So and their results concorded with the upstaging with the previously shown results. But interestingly, in this particular study, they have also evaluated the cost and radiation dose between the two groups. And they found that the cost is comparable between PET scan and combination of CT scan and bone scan. And radiation dose was much less with PET CT scan compared to the other group.
Sorry to interrupt, Doctor. 3 minutes left.
Sorry?
3 minutes left.
Sorry.
In value analysis multi-center study also recently published in JNCC showed that the PET CT scan reduced the false positive rate to almost half, and also decreased the number of incidental findings and allowed earlier treatment start. And it was cost effective, and in one of their institutions, it was cost saving. So obviously there is a growing evidence that PET scan has a role in stage migration and impact in treatment. Also allows avoidance of unnecessary treatments and its side effects. Additionally, allow minimization of radiation and potential cure for oligometastatic lesions when detected early on in the disease process. The rate of stage migration after PET CT scan in breast cancer patient, especially stage 3 and stage 2B, are not significantly different from reported impact on stage 1 non-small cell lung cancer and head and neck squamous cell cancer, where PET CT scan is recommended by guidelines and covered by Medicare. So for this reason, the PET CT scan I think will find its way in the clinical guidelines sooner or later, but the question is where it will be placed as a standard of care. This is the SMO recommendation of 2019. Again, similar to the NCC guidelines, does not encourage the regular use of imaging for staging, and except in locally advanced tumors. However, interestingly, they have mentioned that the use of PET CT scan may replace traditional imaging in high-risk patients, rather than being a complementary tool to conventional imaging. The clinical practice guidelines published recently in European Journal of Nuclear Medicine, which was awarded the label status by French National Health Authority and French Cancer, states that the PET CT scan is recommended for breast cancer starting from stage 2B or higher. This is an interesting study, though has small number of patients when compared the performance of PET CT versus CT scan when used for staging and monitoring response. In their study, they have shown that the PET CT is much predictor of or better predictor for progression-free survival and disease specific survival for first line and second line therapies with good separation, as you see in the graph. Okay, at the end, I just want to mention that most of my talk was related to FDG, but I just want to remind you there are other non-FDG PET tracers available, which can image a bone like NAF or estrogen receptor like F18 FES PET scan, or progesterone receptors or HER2 receptors, and so on and so forth. But just want to show one slide about the estrogen receptor PET CT scans, and this has shown very excellent correlation with the degree of ER staining in immunohistochemistry, which allow in vivo ER expression evaluation. And by this, you could assess the heterogeneity of ER receptors in patients with metastasis in different parts of the body, and also was found to be much higher sensitive and specific than FDG PET scan in patients with estrogen receptor positives. This is a patient with ER positive disease, where there is detectability of the metastatic lesions both in FDG and PET scan. However, in the patient with negative ER, you see that the FDG show the disease in hilar lymph nodes. However, they appear negative in FES PET scan. This was my last slide, and thank you for your kind attention.
Thank you. The mic on. Thank Dr. Zayed. Now it's my pleasure to introduce Dr. Hayat Al-Rabia. Because breast cancer is unfortunately the disease of young women. And unfortunately, it's at the beginning of their reproductive years. Some of them even not yet married. And to their surprise, they are diagnosed with breast cancer, or sometimes they are just newly married. We sometimes receive, as a gynecologist or obstetrician, that the patient diagnosed for the first time as a breast cancer when they are coming back from their honeymoon. And Dr. Nafisa so many times referred to us a lot of patients when they are just recently diagnosed as a pregnant and they are diagnosed as a breast cancer. So for the coming 20 minutes, we are going to listen to Dr. Hayat Al-Rabia about a very interesting topic about fertility preservation in a breast cancer women. Dr. Hayat Al-Rabia is a well-known physician. She's a consultant and section head of IVF in our units, King Abdulaziz Medical City. As well, she is a program director of IVF Fellowship. She is having many certificates in the world, but without any further ado, we are going to waiting to hear from you, Dr. Hayat, about fertility preservation in breast cancer.